Um, Thank you so much for the opportunity to present. A huge thanks to the HIV Institute and the SDCFAR to be able to share with you some evolutions in my research and career trajectory. And I want to own that these are my experiences, and hopefully it will add some points for good discussion moving forward. And these are experiences I've had for almost 20 years now. And in terms of some housekeeping to get started, I have no disclosures to declare, but for our objectives today, my goals are simple. I hope to describe the development of what has become a strong research career, explore a lot of the uncertainties and opportunities that help to shape my trajectory, acknowledge some of my successes alongside the inevitable road bumps to success, and have an open discussion on strategies that have helped to sustain this momentum and passion for this work over many failures and that I've experienced in the 20 years, alongside some of successes. And so I will just move through the slide deck. The way it's set up is more for talking points for me than it is necessarily to read the text. So I hope this will be a bit more conversational at the end. And please don't hesitate to drop comments or questions you have along the way in the chat, and we can review them. But I will proceed unless someone comes off unmutes and to ask me a question as I go through, which is totally fine. It's hard to navigate the chat and slide decks with one monitor. Okay, housekeeping done. Let's get started. A lot of folks on this call I have the opportunity and pleasure of already knowing, but for those of you who I haven't gotten to know as well, just as a brief overview, I'm a social psychologist and I use multiple and multi-level methods to ask, how can we improve equitable access to engagement in available treatment and prevention services, health services, and therapeutics? And my guiding research question primarily focuses on the socio-structural drivers of health equity. And this focus builds synergies across my research, teaching, mentorship, and service, some of which I'll touch on today. And my focus also aims to prioritize health equity in medically marginalized communities, particularly those who are affected by HIV and substance use. When I was first asked to give a career trajectory talk, I had to stop and pause and think about where I am. My current status as an associate professor here at UCSD, and really kind of reflect on the path up to this point and whether I could even give a career trajectory talk, because I was surprised when that email showed up in my inbox. And as I started to reflect on it, I was like, oh, you know what? I think I can give this talk. And I think I have some fun things to say about my journey up to this point. And so the things that I really want to lift up is that it was an evolution. There was no direct path. And this evolution consisted of uncertainties, opportunities, and some successes across many different phases of my career, beginning with my formative frontline work in Seattle, King County, moving on to earn my PhD at the University of Connecticut, coming to UCSD as a T32 postdoctoral fellow, transitioning into my position as an assistant professor that spanned both the early years and the dreaded K-Cliff, and then finally where I've landed and currently am sitting as an associate professor. And so beginning this journey with some of my early frontline work, from those years after undergrad, I focused intentionally on moving from community service work into research. I worked as frontline staff at a social detox in the emergency room, doing adult protective custody holds, which meant I was responsible for the well-being of folks who were intoxicated and deemed by other people to be a danger to themselves or others. I moved into working for a women's work release home, and then finally into Seattle King County Public Health HIV/AIDS branch, and simultaneously working at the University of Washington as a research assistant. So this sounds lovely, but this period had a lot of uncertainties. And in particular, in my frontline work, I observed just blatant and horrific discrimination at all levels of these systems, working in the detox and the women's work release primarily. And I just felt helpless to change things from my role in frontline service work. And I already knew that I wanted to go to graduate school and study HIV and substance use research, but my mentors in undergrad were very kind and told me very directly that I didn't come from an R1 institution, and there is no way I would be competitive off the bat. I was going to need to get more research experience, and so as soon as I graduated, I worked in the field, but I started applying for every RA position. And this was back in the time when there was actually a weekly newspaper with job postings. And so I would grab the stranger and I would go to the job postings and I'd start circling every research assistant position job and I would apply. And there were always new RA positions being posted through the University of Washington. And I would call and follow up on my application and I'd do all of the things that I read that you're supposed to do to be successful. And I got no callbacks, absolutely none. And then there was an ad for an administrative assistant position, which was my first opportunity to get my foot in the door. Was I looking for an administrative assistant position versus a research position? Well, this was with the HIV/AIDS Planning Council. It was with Seattle-King County Public Health. I could type. I had a good organizational sense. I could communicate with people. Why not go for it? So I applied. And in my interview, I explained to the director of the Planning Council, Jesse Chips, that I was really excited for this opportunity and hope to use it to go to grad school and get my foot in the door at Seattle-King County Public Health. So by the time she called me to let me know I got the position, she told me my first learning opportunity was to never tell anybody I was taking a position to leave them ever again. And but she was excited for my passion for what I wanted to do with the work, and she was willing to give me a chance. So from there, she circulated my resume to all of the University of Washington researchers on the Planning Council, and in less than 2 weeks, I had 6 offers for an RA position. And I took 2 volunteer research positions from those opportunities, where I conducted field interviews with homeless and street-involved youth at shelters and out on the streets, and then also with residents of the First Wet House, or First program here in the US, where they provided housing to people with alcohol use disorder who had been chronically homeless for decades without mandated sobriety. And I was the first person to talk to when they came in and had received their housing. I used these experiences to then take on the field coordinator role of the very first National HIV Behavioral Surveillance Survey in Seattle-King County Public Health. And so for those of you who know when that survey emerged, you have an idea of how long ago that was. And for those of you who don't, that's fine. No need to look it up. But these opportunities really moved into some important successes. In particular, my frontline work informed my desire to reduce barriers to engaging in healthcare. What I observed in those frontline service positions was untenable and something I was motivated to do better on. The Planning Council at the time was championing the need to prioritize ART adherence as a prevention tool, which now sounds, of course, why wouldn't we do that? But this was back in the days before HPTN 052, before we had any empirical data on U equals U, and yet the frontline workers, in their knowledge of where the innovation needed to be staged a coup, that all primary prevention dollars needed to go to support ART adherence as a prevention tool if we were to have an impact on our local epidemic, right? And I'm sitting there as I'm taking the minutes for these meetings and thinking to myself, this assumes people have access to care. Everything about my formative field frontline positions tells me that the people who are going to need ART adherence support the most don't have consistent access to care. And so I wanted to know how to reduce barriers to care as the antecedent to ART adherence. And it took 2 years and 16 applications to get into grad school. But I got there and I moved to the University of Connecticut, where I earned my PhD in social psychology. And I leveraged what I had learned in the field to study factors that affect engagement and retention and care among people with HIV and people with substance use disorders in clinical settings. Some of the uncertainties at that time was one of the biggest one was very personal. Yukon was very far removed from my communities, and I did not fit in. I did not fit in as as a resident of Connecticut, and I did not fit in as a typical graduate student. And this was apparent in that, like, unlike my other peers, I knew nothing about theory. And I didn't know, because of that, I didn't know how to tie my experiences directly to research opportunities, right? I came from the field, not from an R1 institution. But there were a lot of opportunities that I had while a graduate student, and some of the most important ones I'm lifting up now. My co-mentor Revea Miko was doing some analysis work with Shinazo Cunningham, who had an R25. I'm naming that mechanism specifically because that meant she had protected time to mentor and support emerging investigators, and she chose to use that time to invest in me. She gave me an immersive clinic experience at Montefiore in the Bronx, and thanks to Metro North, I was able to commute from Connecticut to the Bronx and back again to complete my master's thesis and dissertation work with her clinic population. I also got 2 seed grants, and these each were $1,500, so they weren't a ton of money, but they allowed me to do formative qualitative work studying barriers to HIV care utilization and advanced stigma measurement in relation to HIV drug use and MMT. And they did that in partnership with my grad school colleague, Valerie Earnshaw. And I also earned an F31. And one of the reasons I was willing to move to Connecticut for 5 years was because my mentor, Jeff Fisher, had a successful track record of his mentees getting F31s. And I didn't have a full understanding of the NIH funding system, but I understood that to be an important foothold for an NIH funded research trajectory. So I sucked it up and went to UConn and was fortunate to be able to then develop a brief intervention in order to promote retention in HIV care. Some important successes came. As I was developing this work, the care cascade was just starting to come into focus, right? And so the seminal papers from Mike Mogavero and Tom Giordano were published in 2017 as I was starting, and I was able to anchor and establish my training and expertise in this emerging field and engagement in HIV care. I also established expertise in stigma theory and measurement, which Val and I lovingly call our second dissertation. I don't recommend people do it, but we did, and it was a lot of fun to lead that research. And importantly, I loved that I learned that I didn't just love field research and working with participants. I also enjoyed theory and grant writing, and I wanted to move beyond the clinical setting. So when I was looking for a T32, which brought me here to UCSD, I was specifically seeking out postdoctoral positions where I could increase my training in substance use research and get more expertise there, as well as grant writing, and wanted to bring my research from clinical settings back to medically vulnerable communities. And that was something that the T32 substance use and HIV postdoctoral fellowship offered me in spades, right? So then I get here, and my very first uncertainty that hit me was probably the first meeting I had with Dr. Strathty, where I was asked, how am I going to develop a unique research focus? One, that makes my heart go pitter patter and nourishes the passion I have for this work. And two, is competitive enough to fund an entire research career. Of course, I'm a postdoc, I hear entire research career, and it feels slightly overwhelming, but I'm sure Dr. Strathty just meant get the K kid and then go from there. Still, I had some exciting opportunities. There was a lot of research that was being done in HIV at the US-Mexico border region, and it all to date had focused largely on primary prevention. Secondary prevention needs were unknown virtually, and that was my area of expertise. So I was lucky in that I was able to leverage secondary data in order to characterize the HIV care continuum among priority populations in Tijuana in collaboration with Dr. Strathty and our colleagues here at UCSD. And then I also gained some formative exposure to social network methods as an HIV prevention trials network scholar, or HPTN, with HPTN 037 with Dr. Carl Latkin as my mentor there. And some successes that came from these opportunities. I observed that less than 4% of priority populations reporting transmission behaviors in Tijuana were on ART in the context of universal care. I observed that who is in your social network can influence behavior change. And through those experiences, I identified a pathway to advance low barrier engagement in HIV care models with substance involved populations, the niche for a competitive KO1 application that aligned with my passions. So it worked hard and submitted that KO1 and and was able to successfully transition into an assistant professor role here at UCSD, where I focused on expanding independent partnerships and opportunities to address sociostructural factors impeding engagement and retention and care among people with HIV and people with opioid use dependence in community settings, which was the reason I had wanted to come to UCSD from UConn. The uncertainties in this phase were many. First of all, I got the K, hooray! But now I needed to start thinking about, how do I demonstrate my transition to research independence to get to associate, right? I need to think now about that next step. And what does it take to write a competitive R-level grant? KON was one thing, but an R, was a whole new ball game for me. And that ever persistent little buzz in the back of your head asking, will I ever, 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 ever write a competitive R-level grant? The opportunities in this phase that were most important are, that I want to lift up is that I leveraged my previous work with priority populations in Tijuana to secure 2 independent grants. They weren't huge grants, but they were important because the first one was from the Baja California Department of Health in order to improve engagement in HIV care through developing a promotora model in a harm reduction NGO. And I did that collaboratively with my colleague, Dr. Eileen Pipitan. And then also was awarded an SDC-FAR International Pilot Grant, where I was a co-PI to develop the first web-based survey of HIV prevention needs of MSM across Mexico. And an important connection I made through this was connecting with Travis Sanchez at Emory University, who leads the AMA study, and which that connection will come back to my career trajectory later. Some important successes that came from these opportunities is that I was able to show that I could cultivate an independent program of work with priority populations in Mexico, independent of my fabulous mentors. The KO1 let me extend my professional development opportunities with the HPTN in very important ways. I was able to maintain being a non-voting member of the Substance Use Steering Committee and keep attending the annual meetings to advance my training in network level science and really get a sense of what it takes to collaborate on and lead network level science that I never would have understood from an 18-month HPTN scholars position, right? During that time, I submitted my first R1, not scored. I turned it around and submitted an R34, not scored. Both of these were submitted to expand on my F31 retention and care intervention work. Neither were discussed, and it was clear from reviewers' comments there just wasn't enthusiasm for this work, which was devastating because I put so much labor and love into developing that intervention, right? And it had promising results. But it was clear that the pendulum on retention and care was starting to retract, and I had to start to think about how I was going to pivot and look for new opportunities to grow the program of work that I had worked so hard to develop, and that wasn't just tied to this retention and care intervention. And of course, those uncertainties were mounting just as I was summiting that K cliff, right? Not a better time to learn that you need to pivot. But I used that period to really kind of expand the scope and focus of my work. I knew I wanted to be more community engaged, not just leading research in the community, but partnered with community. I wanted to leverage the promise of implementation science and revive my passion for addressing stigma to improve HIV service engagement. And how this happened during this period was definitely in the context of even more uncertainties. How do I cultivate new and innovative research opportunities for community engaged research? Something I knew I wanted, an area I wanted to take my work to. Again, will I ever write a competitive R-level grant? Will I be forced to leave science and need to work at Starbucks? Yes, that was my backup plan. Had to be able to pay rent somehow and get health insurance. And what is this implementation science thing I keep hearing about, right? I heard about it some in grad school. I'm seeing it pop up here and there. And if what I understand about implementation science is true, then it could be a tool with which we can help stop the replication of disparities with each new biomedical advancement, right? We may advance our technologies and our treatments and our therapeutics, but we only seem to replicate and reinforce the same disparities. Is there a way to close that gap in my communities? And the more I started to look into implementation science, I really started to wonder, okay, seriously, what is this? It seems like I should be able to wrap my head around it, but there's pieces that I'm not grasping yet. And so there were a number of important opportunities that came at this phase. I sought institutional support from the SDCFAR to better support HIV research with the trans community. And in that partnership with colleagues, we were able to form and formalize the Transgender Non-Binary Community Advisory Board. In 2018, there was an inter-CFAR implementation science meeting, and I successfully petitioned our CFAR director, thanks Davey, to send me to this meeting at Northwestern with the promise of coming back and saying, what other CFARs are doing in this implementation science arena. Then in 2019, the CFAR and EHE supplements hit that were grounded in implementation science and asked us to build responses out with community partners with FQHCs and CBOs. Partnerships I had already started developing because I had wanted to cultivate new community engaged research. The HPTN was planning its first US protocol with people who inject drugs in years. And I was at that table because I was on the substance use steering committee. So I got to have a say in that planning and in that development. NIH was releasing multiple stigma RFAs, and lo and behold, my second dissertation was expertise was sitting there with the expertise in stigma measurement. And I also, something that may not always come to mind as a formal opportunity, but I invited myself to the Lancet HIV Eastern European and Central Asia meeting. I literally sat there and watched my colleague Dan Werb invite himself to this meeting, and it dawned on me, this is how you get a seat at the table. So I had KO1 funding that was designed to invest in my professional development, and I invested in myself, and I invited myself to that meeting. Some really important successes and non-successes that came up during this time is I submitted 3 R21s back to back in order to integrate HIV and gender affirming care continuums. 2 reviewers thought I was a genius. 1 thought I was an idiot and didn't understand how gender affirming care could have a care continuum akin to HIV, let alone be integrated. I think we've all seen that play out differently since then, but at the time, it wasn't going anywhere. It was below the pay lines, right? However, I was successful in securing 2 CFAR supplements, specifically because we had invested in TCAB and started to build those relationships with the transgender non-binary community, right? And I also, a big success was learning not to be afraid to invite yourself to the table. It led to a stigma R21 in Kyrgyzstan that I led, as well as the PI role in leading the implementation science evaluation for HPTN 094. And neither of them would have been opportunities that I would have had if I had not invested in myself and advocated for myself. My first pass at a stigma R01 was an absolute failure. It was embarrassing. I still avert my eyes, even when I hear the names of people that likely reviewed that grant. And it was a failure because it was driven by survival mode. I was panicked. I was afraid. I needed to land an R01 or everything I had worked so hard for was going to just disappear from out underneath me. At least that's how it felt, right? But my next 2 passes, I was very fortunate. I was able to give myself some grace and had a lot of social support in helping me to find space for that grace so that I could focus more on what it was about my lived experience and the training I had had to date to really sell the innovation that was behind what I was proposing in that grant. And ultimately it scored and got funded at a 17, which is in the exceptional range. That brings me to where I am now. And in this so-called mid-career stage, which still blows my mind every time I hear that. I really have been focusing on expanding the scope of my work with community partners to close the HIV service implementation gap in medically marginalized communities, and being in mid-career, really focusing on ways that I can expand the capacities of early stage investigators, especially those from the communities that I work with, in order to lead this work. This phase is not without uncertainties either, I promise, but they look a little different. One of them was I really wanted to know and started thinking very deeply about how can I center community voices in leadership in the HIV response, move beyond partnership and lift up leadership. I also, am still wondering if the funding support for the EHE and stigma reduction initiatives will hold at NIH, or if that pendulum's going to start to retract and I need to be on the lookout for new ways to move with the science. And as my research portfolio expands, I've spent a lot more time thinking about what do I nurture, what do I delegate, and what do I leverage to champion others, which is a different mindset and a different set of uncertainties and skills to take on. Some opportunities that I've had in this arena are the opportunity to pursue leadership opportunities here at the SDCFAR as a former recipient, as someone who benefited from OK Review, someone who benefited from the pilot program, someone who benefited from developmental grants. They helped me along the way, and I want to reinvest in those coming up behind me. There were also some CHRP R01 level RFAs that came out around this time in order to center the community in the HIV research response in California. And because I had been thinking deeply about how to do that, and that being something I wanted, I had ideas in mind when these landed. I also used the PI-initiated, no RFA, but the PI-initiated R34 mechanism to NIDA to propose a stigma reduction grant, building off my work in Kyrgyzstan. And I leveraged relationships with other funded EHE-IS investigators to seek new CFAR supplemental funding. Oh, I don't know what's happening here. It's not advancing. Maybe. There we go. Okay. Move on to the mouse. So some successes that I've had, and I trust me when I say I count my blessings. I'm now the PI or the MPI of 6 R-level studies. I've navigated changes in community partners and leaderships, which is something entirely new that has emerged at this phase, and I've done that with some success and with some important learning opportunities for community engaged research. I've been fortunate in being able to merge my teaching, mentoring, and service activities in order to build synergies with my research in order to lift up opportunities for new early stage investigators. I want to emphasize that my successes are one example and not the example. And in reflecting on this, I really, am mindful of what my work-life imbalance trade-offs look like, right? And because I think it's a falsehood to suggest that there's an ideal balance out there. It's more about the imbalance and the trade-offs that are going to work for you, and to be mindful of those as you progress up through this stage. So now I sit here as an associate professor, and I'm thinking on, I want to provide a snapshot of what it looks like where I'm at now. Last week, I got the invitation that my promotion materials to go up for full professor are due April 15th. So trust me, I will soon have a whole new slide on uncertainties that are forthcoming. But I thought it would also be important to reflect on some of the lessons learned across this trajectory. And so where I stand now, I've been very fortunate and generated a little over $20 million in funding, both for my PI and MPI led projects as well as co-PI projects. I have a lot of collaborative projects I didn't have time to touch base on, but because I want to provide opportunities for folks who may be in the audience and looking for opportunities to advance their next career stage. I'm going to review a couple of these of the projects that I am PI or MPI on in case they're of interest to you and can support you in the next trajectory. The first two grants, Nexus and LIFT, are both NIH funded. They both scored in the exceptional range, specifically because of their innovation around targeting intersectional stigma as a barrier to treatment and prevention services. And they approach this in two different ways. In Nexus, I developed a novel social network method in order to model the impact of stigma on future health behaviors. In particular, we're looking at HIV testing and PrEP use among 500 Latino MSM here in San Diego County. In LIFT, it's the first study in the Eastern European Central Asia region to use a multi-level intervention approach that aims to both reduce stigma in the community among people who inject drugs, as well as at the clinic level among methadone providers and staff to facilitate engagement and sustained treatment in methadone maintenance treatment. My next two grants I'm going to lift up specifically because they are funded by the UC Office of the President's California HIV/AIDS program. And I think it's important to be mindful of non-NIH funding opportunities that can really lift up and accelerate your career. And the CHRP mechanisms are for California investigators, and they're absolutely phenomenal. And I encourage people to look into them. The first of the studies is the Trans Health Project. The second one is the California Center for HIV Syndemic Policy Research. And the thing that both of these have in common is that I'm funded to help develop community-led solutions to HIV in California. The Trans Health Project specifically is using implementation science methods with Black and Latina transgender community leaders to co-develop a community program that will address the unique experiences in relation to exposure to sex work, violence, and substance use that we know are driving the HIV disparities here in San Diego County. The second one for CalSensen, we're funded along with my co-PIs and colleagues here at UCSD to build the capacity of frontline service organizations to co-lead our HIV syndemic policy research. And this really ties back to my formative work in the field and knowing that these frontline service providers are well aware of where those policy implementation gaps are and ways that we can move it forward to better meet the needs of the communities they serve. The next two studies are both funded by NIH, but they are multi-site studies and highly collaborative. Both of them use implementation science in order to accelerate the research to practice pipeline. In HPTN 094, my protocols will help us learn how to deliver integrated HIV and opioid use disorder care in mobile medical units to people who inject drugs in their local neighborhoods across 5 U.S. cities with very diverse substance use, socio-political, and geographic landscapes, right? Across those diverse experiences, how can we optimize the implementation of this integrated care model? Project RISE, on the other hand, I'm collaborating with other EHE, implementation science investigators, in order to identify strategies to build HIV peer navigation capacity in community-based organizations. And this is important because CBOs often have a deeper reach into medically marginalized communities than health clinics do, even though health clinics are the place where peer navigation as an evidence-based intervention is typically implemented. And so across this trajectory, and reflecting on what are some of the commonalities and takeaways that I can share, I think a really important thing across each of these transition points is that I worked hard to cultivate intentional relationships with different be it with community partners, be it with the CFAR, be it with people at outside organizations that helped me in getting to the next stage, right? And also learning to let my passion nourish me during those uncertain times. There are going to be very sharp peaks and valleys in academic research, and being able to tap into the passion that motivates you for this research to see you through those uncertainties is important, because those uncertainties evolve. along with the opportunities and successes. They don't go away. And also knowing that science will change, and it will change how we respond to HIV. And if we're doing our jobs as scientists correctly, it should change. And we should be prepared and thinking about how we're going to change with it to push progress forward. And in this process, I highly encourage you to seize opportunities, both big and small. It's not just the R01. There's a lot of other opportunities to support a strong career trajectory in order to drive that change forward. And finally, there's no one direct path to success. It was really, in many ways, the second dissertation that I took on at UConn in stigma measurement and the formative training I got in social network methods that allow me to get my first R01 nexus and have the ability to drive innovation in responding to intersectional stigma measurement. It was my experiences in the frontline work that brought me to UCSD to be able to bring my work and my training back to the communities based on the experiences I had in the field. Is that same frontline work that drove my thinking and my passion around how do we go beyond partnerships and really center communities in our work that allowed me to have a competitive edge for those CHRP funded opportunities. And it was in the early K years with the Pilot International grant where I met Travis Sanchez, who leads the AMOS study, and through working on data with that with my T32 mentee, Dr. Angel Algarin, are now leveraging that relationship for Angel to develop his own independent research in Mexico that looks at HIV prevention needs of Latino MSM across the borders. And who knows where that experience will take him, but I really hope that it launches him into his first R01, independent of me. And so with that, where the future goes, who knows? I'll be submitting my faculty file by April 15th. So please send out all of the good vibes with that. But regardless of that outcome, I really look forward to celebrating when our new developmental core pilot grant and OK review recipients stand here in the years to come to give this career trajectory talk. So with that, I'm going to stop sharing and open it up for a dialogue.